Now we're talking about healthcare and how we as Kenyans need to own, like we need to figure out what exactly is going on. How can we be, so because at the end of the day, Doc, it boils down to even who you're voting for. Because, you know, there's politics around everything. Road, nitakufungulia hospitali, nita-ensure sijui nini, wamama watazaa. And it's like, come on, you clearly don't even understand what's going on. And this is the reason why we vote for these people. So you've been invited here today to help us understand. Right. So that when we're going to the ballot or when we're talking to our politicians, we know exactly what we're telling them. Excuse me, wacha panganga, enda waambie this. So before we took the break or before we switched on the microphones, there's something you said about the number of people who become poor every year because of healthcare bills.
1.5 million people become poor every year. In Kenya alone. I'm not talking about Africa or globally. In Kenya alone, become poor because of healthcare bills. And this is how it happens. You are working in, on average, an average Kenyan in the rural community or wherever they are will work 5 to 8 jobs to make a living. Okay? They're selling chicken, they're shoeshine, they're selling newspapers, they're doing this and that. And alongside that, that's kind of the family. The wife is doing this and that. If one person gets sick, the entire income structure collapses. Because maybe one person was doing 3 jobs. Those disappear because they're now in the hospital. Then the other person now has to stop working to start visiting them in hospital. And there is no income. And therefore now they start to rely on the social structure. Harambe, oh, please send me, my wife is sick, my husband is sick, my daughter, my child. And at the end of the day, their income stops and they are poor. We are one sickness away from poverty. Ideally, in a civilized society, nobody should ever have to worry about where the money comes from when they are sick. Nobody should ever have to worry about that. And that's what universal health coverage is about. That you build a system that actually works. It's not about excellence. It's not about having the same quality you have in a private hospital, in a public hospital. It's about outcome. It's about that when a mother is pregnant, you can have a healthy mother and a healthy baby at the end of the delivery. How you achieve that doesn't mean that you have expensive equipment. Basic quality healthcare. Then you ask yourself, how do we make sure we protect the people from having to worry about how to pay for it when they are sick? Because almost 30% of people don't seek care even when they are sick because they fear, how do I do that? And you have to worry about transport, you have to worry about this. So health is the most important investment a government can make. But you know what the challenge is? The challenge is that some of the health interventions require long-term investment. Politicians are thinking in 5 years. And they're thinking in 5 years as I go back for votes, what will I show the people? Therefore, I'm going to build a big hospital, which has no doctors, no medicine, nothing. It is basically a form of a substance. So the people must take charge of healthcare. That's the only. Politicians will not deliver healthcare. They must understand and start to actually make political choices based on health investments and education investments. Those are the 2 most important things we can do for any country.
You know, Doc, you've mentioned that any Kenyan should be able to go to the hospital and not worry about how they're going to pay for this.
Yes.
Most of us, what you've just said is foreign. It sounds like something maybe for Wazungu. In a first world country.
Exactly.
We've never experienced anything like that. We have just slowly come from, forgetting about, dawa, it's called what, your traditional herbs. Because any time you think of going to a hospital, bills.
And the issue is, you see, in Kenya, if you look at, if you go to a dispensary, if you go to a health center, those places are free. They have been free from 2012. But when you go there, you are told, okay, I've checked you. You don't have to pay anything. But here's a prescription. Go to the pharmacy and buy
medicine.
That's the challenge. So if you have a problem, first you can't get a diagnostic equipment. So even if you're developing cancer, maybe this was causing the pain, you need early diagnosis. I don't know that you know that 80% of all the people with cancer go to the hospital when they're in stage 3, 4. Okay? So, and maybe they were seen. They have actually been in the facility many times, but they never got diagnosed. But because they don't have money, they're told, you go do this test. Then you go to the lab, you're told, this thing is 3,000. Then you're like, hey, wacha kwanza niende nilime, then I will probably get some money and come and pay. In the process, the cancer is getting worse. So you must remove point of service costs. That's the convention around UHC. You must remove the pay at the point of service. So then people can seek healthcare.
All right, let's talk about funding. You know, because there's NHIF that has been brought in the which is supposed to be helping. But let's not talk about NHIF. Let's use Ghana as an example. Yeah. Ghana is one of those countries that has, universal health coverage for all, guys. An African country that actually has decided UHC is the way to go. There are about 9 African countries that are on that tip. So because the conversation is this something we can sustain, or is this just a political promise that we need to look at? 50 years is what it will take for us to be able to attain it. Yeah. When you look at Ghana, they've dealt with the basics. One being insurance schemes that work. The NHIF that actually covers everyone. We have NHIF. What are the challenges?
The challenges are that I have talked about this, that the issue is the base of the pyramid. It's the poor people that we must first worry about. Okay? Now, if you have NHIF that focuses on the private sector, you're not getting anywhere. All right? What Ghana did is say, we are going to start a social insurance scheme. Let's not even NHIF, whatever. Yeah. It's a social insurance scheme that starts with the poor. So they took their VAT, added a little of it, and put that money into healthcare and provided everyone with an insurance cover. Yeah. So when you go to the hospital or you go to a facility, you actually have listed services you get. Just as soon as you show that card, you get services. This is also going on in Rwanda. Rwanda, about 90+% of their people have a card. You just walk in, you get care, and you go away. Now, the problem with our NHIF is that it has focused on private sector. It has started to participate in commercial schemes where it's competing with other private insurances. Yes. The only way to resolve NHIF is drop the commercial competition. Convert NHIF, because it's a public facility, it's a public institution. Convert it to social health insurance, which has 2 things. Mandatory payments, which you and I pay. Yes. Then the government takes our taxes, identifies the poor people, and gives all of them, using our taxes, NHIF cards. Then you have 60-70% of people in NHIF. Then the rest of the people who are doing matatu business, they own butcheries, shops, and they can afford, they are then forced to actually contribute. You say, before you renew your butchery license, show us NHIF. Then you're sorted. So the models exist, but the politics interfere.
Kenyans Miskia. You can actually access healthcare, but politics is interfering with you getting to what you need. It's Dr. Githinji. He's the CEO of Amref. We're going to come back. Whatever questions, we're going to open the phone lines at some point. But when we come back, we're going to talk about facilities.
Good vibes only on Vibes Radio.
104.5 Vibes Radio. You are locked onto the biggest show, especially when you want to catch good vibes, you want to catch some information, you want to listen to some nice reggae, you want to go to work energized and and your mind has been exercised. It's Kwambox Mbunde, and we've got Dr. Githinji in studio. Now, Dr. Githinji, we're talking about universal health coverage. Is it something we can attain?
It is something we can attain. I think, there's something you referred to earlier, which is about funds, about affordability, which is important for Kenyans to understand. Today, if you average the amount of money that Kenya uses per person on healthcare, you take all the money used and divide by the population, it is 3,000 shillings per person per year. If you look at United Kingdom, it is 400,000 per person per year. Oh, wow. If you look at the USA, it's about 600,000 per person per year. Wow. That's public expenditure only. You're not talking about the money we spend in the pharmacy. If you look at that, it's a different picture. So you can actually tell that we have very little money. And this is across the African countries. It's because of the size of our economies. Which then comes to the question of making the right choices, priorities, and efficiency. It is so critical that when you're poor, that you focus on efficiency and priorities, that you cannot afford waste when you have nothing. US can afford waste, we can't afford waste. So it's affordable and it's manageable by first deciding what set of services are we going to offer the people without worrying about how they pay for it. Then we make sure the public facilities are able to provide those promised services without fail. If I say you'll find antibiotics, you will find them.
Yeah.
If I say you won't find cancer medicine, then it's okay. You know you won't find it. So there is a predictability.
Yeah.
And then finally deciding what are your priority populations. There's no need of offering me as the CEO of Amref an NHIF package. I can pay for it.
Yes.
Even my mother, I can pay for my mother. But what about the people who can't afford? Those are the responsibility of the state. And I will tell you that I've done some quick calculation. If the state decided to offer everyone who is poor an NHIF package at the current 6,000 shillings, they don't need more than 30 billion shillings to offer more than 40% of the population this card from our taxes.
Didn't NHIF come out and say that they wanted every Kenyan to pay 6,000 bob to get access to NHIF?
But Kenyans can't afford. So we had actually, we tried these things. We went to Laikipia as Amref.
Yeah.
We sent community health workers house to house. We visited 110,000 households. Only 19% people could actually pay NHIF.
Yeah.
So you have a big problem that there are a lot of poor people. Many people are living under $2 a day.
Many people are living in mud huts and still
In mud
using
huts.
cow dung.
Exactly. So what the government needs to do is this effort of, I don't know, Huduma number, social protection, labor. They need to work with the communities, especially community health workers, go house to house, look at how many people have chicken, do you have children, do you have what, then classify these people. It's a useful exercise. Then say, everyone who falls here, and people can even open up their phones for us to check their mobile money transactions. You can tell who a poor person is.
Yeah.
Then you say, for all these people, the government will give you a free card for NHIF, and then all these people enter into NHIF. Then NHIF stops paying money to private hospitals, starts paying money to the public hospitals,
yeah.
and then that money then used to improve public hospitals. So then you go to Kenyatta, Mbagathi, Nyandarua, Kiambu, you find the services you need without having to worry. And it won't mean you'll find everything.
Yeah.
The government can decide for this, we are not able to pay because we only have 3,000 per person.
Yeah.
Then those we know that if you have this, we'll then do a harambe because we know you can't afford these ones.
Yeah.
But it needs to be clear, predictable, and systematized and institutionalized.
Speaking about improving healthcare to the guys on the ground, it's about time, because we always speak with Kwambox each and every day, and we are tired of hearing stories of guys moving from Wajir to Kenyatta just to access these cancer machines. Is it about time each and every county purchase the same level of high-level equipment down to the counties?
Yeah, because there was an issue, just to add on to what he was saying. There's the issue that when we're talking about their governor, I think 3 weeks ago, and we're asking, how is, because the governor, it's devolved. Your governor is the one who's supposed to be handling what's happening in your county. But if you have a governor who's focused on building, schools, adding more classrooms, but there are no, books or just whatever, some opening a wheelbarrow or something, and is not focused on that, is it something we can attain? Because every county is involved with prioritizing what their county wants.
Right. You see, I want us to be very realistic. Number one, on one side, when we talk about cancer, we need to realize that the key killers in cancer is cervical cancer, for women, breast cancer, for men is prostate. These are the key killers. And these, a majority of them are preventable. So what the government has done by providing HPV vaccine for young girls, fantastic. So we
Screening
must give
well.
credit where it is. So all young girls are receiving HPV vaccine, which means they won't get cervical cancer.
Yes.
That's a major good step.
That's good.
Okay? Now, when you then get to the county, let's talk about the county system. Now, if you look at the counties, they receive about 320 billion a year. That's what they receive. They spend a quarter of that on healthcare. You see, the government spends much less out of its total budget on healthcare. So the counties are actually doing very well. They're spending a quarter of their money in healthcare. But you know where that money is going? It's going to paying health workers. 70% of it is health workers. So how much do you have? Take 90 billion, which is a quarter of 360, if you are to even make it 360 billion, and then remove 70%, and then you're left with 20 billion shillings or so to buy medicines, to buy equipment for cancer. It's for 47 counties. Not possible. So the arithmetic just tell you that you need to focus on primary health care, the basics, and then you don't need a cancer center in every county. You need the government to build centers of excellence to be shared regionally. So that you say, for example, this particular place in this place will cover 6 counties. This other one will cover, and that needs to be supported by the national government. The counties need to focus on vaccination, providing community health workers, providing nurses, immunization, maternal health when a mother is pregnant, making sure they go for antenatal, basic delivery, pneumonia treatment. That's where they should focus their 90 billion on. The national government needs to pick up the higher care level, and then everyone then stops we all work together to do preventive and promotive care. Then we can start to build a health system from what we have.
You've mentioned that some of the amount of cash that goes to the county government goes to paying the health workers. But each and every year,
health workers are complaining.
They're on strikes.
Yes, that's a problem because, again, we have to ask ourselves, who is a health worker? Okay? So when you talk about health worker to a lay person, they see doctor.
Okay.
But do you know how many people need to see doctors on a regular basis?
Very few.
20%.
Yeah.
Okay.
The majority of the people, the backbone of the health system is nurses. And then at the bottom, you should actually have community health workers who actually visit house to house. Community health workers are not even employed now. They're volunteers. And they are community members. They're never posted.
Okay.
It is in your village. That guy who runs the church committee is your community health worker.
Yeah.
So they know everyone in the church. They go to your household. They say, by the way, you should be changing your diet. Those are the people we need to invest in because they keep people healthy.
Yeah.
Then after that, start to build a strong nursing system because the nurses will do most of even midwifery deliveries, nurses, then start to go up like that. So when you talk about health workers, you must ask what are we talking about?
Yeah.
Doctors are regularly on strike.
Yeah.
Nurses not as regular. Community health workers, we never had a strike for community health workers. So let's focus on where the need is and then build a good referral system. So where you need doctors, you need nurses, you need everything works together. All the health workers are important. But let's not focus on one cadre or the other. We must build a health system that is comprehensive with a good referral system, starting at the bottom, moving up, not top down.
But what's the incentive for me as a health worker to work in a public hospital vis-a-vis if I got a placement in a private place? Look at some of the doctors we have. Like if you're looking at public hospitals, like I give an example here, how I went to a private hospital and I sat for over 2 weeks waiting for the doctor to show up to finish with his practice at the public hospital and then come to the private. Here in a country where you have thousands and thousands of doctors graduating, where are they going?
So we have two problems when you talk about health workers. We have a problem of production and we have a problem of absorption. So the public health sector, because of the economics I talked about earlier, about the money, is only able to absorb a certain number. They don't absorb what they need. They absorb what they can afford. So all these workers we are producing, I think Kenya is producing maybe close to 1,000 doctors a year. Wow. Now, we can't absorb that number. So many of them will do some jobs here and there. In fact, one of the challenges, and I know there was a report, this is not from me, there was a report called the Service Delivery Index that said absenteeism of doctors in public facilities is up to 60%.
Yes.
Why? Because they actually share duties. Say, you work this week, me, I'll work the other week, all these kinds of things. Yeah. But absenteeism of nurses is much lower. It's at 40%.
Yeah.
So the nurses are the ones actually day to day are doing, most of this work. So the challenge is that some of the doctors, when you go to the hospital, if you're a doctor, it means that you are also assigned higher level tasks. Okay? But if there is no CT scan, therefore you can't do a CT scan on a patient to decide what to do, then what are you doing in the hospital? You see, so you go and work in private, and then the patients who need CT scan are referred to Kenyatta. But if there was a CT scan, if there was an X-ray, if there was a theater that had an anesthesia machine, then you would wait because there are patients coming. But in many hospitals, they just refer. I'll give you, I know we don't have much time. I'll give you an example of a relative of mine who died 2 weeks ago. This guy was 62 years old. He started having a headache. He went to a local clinic. The guy in the local clinic said, hey, you go to Kiambu. I'll give you Panadol, but I'm not sure what's causing your headache. So the guy goes to the clinic, to the Kiambu hospital. Then Kiambu hospital tells him, hey, you go to Kenyatta. Yes. Okay? So within this time, it's about 2-3 days. So all he needed was a CT scan in Kiambu. I don't know why they didn't do it. I don't know. They say, hey, you go to Kenyatta. Went to Kenyatta with his wife, and he was walking by Matatu going. He waits in the queue. Then he collapses in the queue and dies. Wow. Okay? So if the people in Kiambu are able to attend to him, it is likely, because he had a stroke, it's likely he would have been saved. Yeah. Okay? So this is the problem. So does it mean the doctor in Kiambu had a problem? If the equipment to do the CT scan was not available, what could the doctor have done? So it is an entire system we need to look at, all the way from the bottom to the top. And no single health investment is less important than the other. Yeah. They are all important, but we must decide What are we offering? Why would I have an MRI and I can't do somebody blood test?
Yeah.
Why would I have an ultrasound if I can't give a mother blood when they're bleeding? It's useless.
Why would I open a Kenyan National Blood Transfusion Center
Yes.
and not have blood?
Exactly.
So we're
What
going to
should
come
you
back.
invest in?
We're
Yeah.
going to come back and talk about, because we are in that process of vetting a new CS for health. Cicely Karaoke had a lot of challenges. So there's a new person who's coming in. What are our recommendations?
Good vibes only on Vibes Radio.
Well, this is a difficult question to answer, and therefore difficult answers, difficult answer to give. But, from what we understand and what we see, Makueni has a good healthcare system. And it's not because they offer better quality healthcare than the other county. It is because there is intention. That's what I'm saying is a difficult question to answer. Because healthcare is about the intent of the policymakers and the truthfulness and openness and accountability of building a good health system.
Yeah.
So Makueni may not be state of the art. So when we talk about good healthcare, we don't say, they have 10 MRIs.
Yes.
No. Is that a mother can walk in, get checked compassionately. There was a question to 1.2 million women across the world.
Yeah.
And they were asked, what would you really like when you're pregnant for you to feel you are well taken care of? Do you know what they said? Compassion and good hygiene.
That's
They
it.
never talked about doctors, our own gynecologists, our own ultrasound. No. So I would say that Makueni is starting to develop a system where the health workers are motivated enough to give good quality health care, which is basic. It's not about the machinery. So Nairobi, where we say, Nairobi has good health care.
Yeah.
Do you know Nairobi has the highest death of young children under 1 month? Across the country. Yet we think Nairobi has good infrastructure.
Yeah.
Okay? So it's about quality. And quality is defined by the user.
Yeah.
It's not defined by me as the doctor saying this. It's the user. Were you happy? And did you get a good outcome? So I would say Makueni is on the way there. But many other counties like Laikipia are doing very well. They're starting to bring down the services to the people.
Yeah.
They're starting to pay NHIF for the poor as well.
Yeah.
And they have a really good intention. So those are the two I would say that are actually making steps. But we must redefine quality in our minds. Not cancer centers, primary healthcare and
like
good
that.
intention.
I like that. Okay. Why are we supposed to wash our hands? I know it's a silly question, but I know that there's a massive campaign around the world to get people to wash their hands. Initially, it was children. So you have the brands that would be like, teaching kids how to wash. But you can teach the kid, but if the parent doesn't know, it's a waste of time. So why do we need to wash our hands?
What an important question, because let me tell you something. If you look at the United Kingdom, even before antibiotics were discovered, even before there were medicines to treat pneumonia, diarrhea, the biggest change in the United Kingdom was somebody who said the reason people are getting sick is because of this River Thames, because it's dirty. So they introduced something called the Public Sanitation Act. That is what actually reduced death across the UK, not the medicine. The medicines came later.
Yeah.
Now, if you look at child deaths in the last 20 years, they have reduced by half. But the biggest contributor is hygiene. It's not hospitals.
Yeah.
It's hygiene. Now, your hands are the entry port for diseases. When you have a child, you're using them to clean the child. You're using them to feed the child.
Yeah.
You're feeding yourself. So the hands are the end, and therefore everything you do, if you have to put anything in your mouth, which is the main gate to disease, you have to wash your hands. Look at corona. What is the biggest advice for people to protect themselves against corona? Wash your hands. If you look at a flu, what is the biggest advice? Wash your hands.
Yes.
If you meet somebody coughing, in fact, I used to train people and tell them it's easier to kiss somebody than to shake their hands when they have a flu. Okay? I've not told you to go kissing people on the street, but it's actually safer to kiss them than shake their hands if they have a flu and they haven't washed their hands. So wash your hands. Mothers who are pregnant, you're getting your child and you need to handle your young child. If you don't wash your hands, your child will die before they're 1 month old.
Wow.
Exactly. Because you'll transmit diseases. So washing hands is one of the most basic and most neglected form of healthcare.
Imagine that.
Yes.
But the communication is not really out there. So I think one thing that, this incoming CS needs to also look at is how to disseminate information. I think just the government as a whole, you need to figure out how to disseminate information.
But hand washing will not give you votes. What will give you votes is a cancer center. This is the problem.
Yes.
So we must distinguish. We must let the people own the healthcare, not be driven by a political agenda.
Doc, I think we're going to keep inviting you here as a friend of
you.
Vibes to, share with us all this wealth of information. I know there are people who've been going to work, sitting in the parking lot, not even going in because the conversation was so sweet. We're going to invite you again. Thank you so much for making the time. And that was Dr. Githinji, CEO of Amref. What have you learned?
Need to wash your hands. And I'll be going to Makueni when I feel unwell.
Yeah, for sure. Because they have